Welcome to Schaefer Eye Center. I know it may be strange watching this video with me talking to you, but I wanted you to get a feeling of what I think about Schaefer Eye Center. And there's some little things I think you need to know as doctors. I hope you enjoyed watching the video of what we show every new employee about the Schaefer Eye Care experience. Well, you're in charge of the Schaefer Eye Care experience. Everything is built around us, the doctors. So make sure you pay attention and staff do what you saw on that video. Smile to their patients, greet them standing up, and their day is spent in a patient-oriented fashion because we are the leaders. So now let's talk about the Schaefer Eye Care experience for doctors. As you know, I lecture all over the country, and in every lecture I give, no matter what it's on, I talk about the medical model eye exam. What's important to know here is whether you're dealing with contacts, glasses, dry eye, it's still the same basic medical model, and it's up to you, the doctor, to decide what has to happen to this patient. When you have an eye exam that's done by a managed care company, whether it be VSP, VCP, iMed, Spectera, and you'll know them all, you have to triage that patient. That is not a medical eye exam. So when you have a patient that you discover during that may have a dry eye, or has flashes of floaters, or may have something on the cornea that you really want to look at, it's your job to book them back with a medical eye care exam. The refractive exams are not medical exams. They weren't meant to be medical exams. We as doctors have to be proud of who we are. We're optometrists. We are there to give medical care. And when they do have this problem, it's you triaging the patients, and simple, I say it every day, oh, by the way, you have VSP, that's going to cover your eye exam today and your glasses. By the way, I noticed you said your eyes feel uncomfortable or a little bit dry. I'm going to have you back and use your medical insurance, your Blue Cross Blue Shield, your other medical, your Cigna, and we're going to do a dry eye or ocular surface disease evaluation to really determine what it is I want to treat you with. One of the biggest problems I see in every office that I go visit is a patient comes in with one of these refractive exams, the doctor does an eye exam and say, here's an artificial tear. What a waste. Even worse is, oh, by the way, here's a prescription for an allergy medicine. You have allergies. How do you know that? You don't know that till you evaluate the entire ocular surface, which it requires a medical eye examination. Be proud of who you are. Be proud of our profession, and remember to separate medical from refractive. Next, let's talk about the Schaefer Wellness Exam. We are working on an exam that patients will come to, whether they have managed care or not, where we can actually provide the highest level of eye exam. What is the highest level of eye exam? Well, make no mistake about it. An eye exam with dilation and an OptiMap is truly the only way to see everything on the eye. You know what evidence-based medicine means. When I lecture, that's all I talk about is EBM. Well, EBM has shown over and over again that 25% of things missed in the eye are not missed when you do a dilation and an OptiMap. We love OptiMap exams, but when you do an OptiMap in lieu of dilation, when you've never seen that patient, or it's a 3 or 4 diopter myope every year, you're doing our patient a disservice. You're cutting corners, and we don't cut corners. We know that we miss holes, tears, doctors all over the country, but we don't at Schaefer Eye Center. So keep in mind, the wellness exam includes an OptiMap and dilation. Now, if a patient comes back to second year and they're 1, 2, 3 diopter myope, and you get a great OptiMap the second year, skip dilation. Let them know you don't have to be dilated this year. But the third or fourth year, you need to dilate. Now, doctors tell me all the time, well, my patients won't do OptiMaps. In my practice, 85% of all my patients do OptiMaps. So I know that it can be done. Around the country, the average doctor that has an OptiMap, over 65% of their patients pay for OptiMaps. So if you're not doing OptiMaps, one of 3 things is happening. Number 1, your staff's not explaining it properly, which it's up to you to train them. Number 2, you're not explaining it properly. Or number 3, you truly don't believe in it. So I'm asking you to believe in evidence-based medicines. Stand up. Be better than everybody else. Give people the care they need. And when you do the OptiMap, make sure you show to the patient everything you see, especially when you see things like nevuses that we know are missed so often without the Optimap, because before we had the Optimap, we're picking up all these nevuses we never saw before, and we're seeing those patients every 6 months, just as we're supposed to. Next is medical protocols. Hopefully Dr. Brooke Schaefer Kaplan or Mark Schaefer, by the time you see this, have worked on our protocols, so we all have these in writing for you. But right now, if you discover GPC and a Schaefer-Osden, every time you see a contact lens patient, you're inverting their eyes, and you do an over-refraction over the lens and a refraction on the eye to determine, is this patient doing a good job? So, with GPC, we have a written protocol. I've lectured all over the world with this protocol, and Melton and Thomas, I know you've seen, have adopted that protocol when they lecture. So I assure you it is well founded in how to deal with GPC. It is expensive, but it's truly the only way to make patients better. Follow it. PVD, 1 day, 1 week, 1 month. That could be 1 day and 2 weeks. But when you see a PVD, flashes, floaters, or any change in the eye, we know that over 7 to 10 days that eye can change. In this practice alone, I've seen twice where a hole is turned into a tear, a non-hole is turned into a tear within 7 days. So make sure 7 to 10 days you see that patient back for a second dilation. In my hands, I redo the Optimap. And I charge the patient. I think it's so important. And then you have them back in 1 month. 1 day, 1 to 2 weeks, 1 month. And if the flashes continue, you see them every 4 to 6 weeks until those flashes stop, or till 6 months passes and then you can spread it out a little bit more. Follow the PVD protocol and you'll take great care. The same thing with systemic meds and glaucoma. If someone's on Plaquenil, we have a written protocol. Follow it. It's so important. And we have to get letters to the doctors about that. We understand that optometry is in charge of the eye care medical model. We need to be a leader at Schaefer-Osden, and we're not average here. We are above average. We do the best. So when patients come in, make sure that physicians get a letter of what's happening with their eye. It'll pay off in the long run, not only in giving better care to that patient, and really this is what it's about, but also in developing your profession, optometry, as the leader in medical eye care. Macular degeneration. You know, the most feared disease of all is macular degeneration. And at Schaefer-Osden Center, we now are developing the Center for Macular Health. What does that mean? When you see a patient with a drusen, I don't care if it's one single drusen, you need to have a conversation. Any family history. If there's a family history, you want to genetically test that person if they are willing to find out are they a 1 to 5 category on possibly a developing macular degeneration. Second is OCT. Always get an OCT within 2 weeks of that eye exam. Do a visual field and a photograph at the eye exam. Within 2 weeks, do that OCT and do a complete assessment of what is it that you're really seeing. We have the equipment. Use it and use it properly. And next is vitamins. As of this point, we actually are selling vitamins, so we make sure that patients are using the best vitamins possible. And you may ask, how do we know? Because Stuart Ricker in Chicago has done more research than anybody in this world on vitamins. He happens to be a very close friend. We lecture together, and every 6 months he puts a panel together, he calls us and he tells us, here's what I think is the best on the market. And the vitamins we have usually come straight from his recommendation. So remember, you can prevent long-term macular disease in some of your patients if you get them in, keep them under control, and make sure we have the tests to know are there any changes going on. Now let's talk about surgical referrals. It's real important that we start tracking everything that refers, whether it be cataract or glaucoma surgery. Make sure that you track it and we know where it is. Now, as far as glaucoma, if you're not comfortable with what you're doing, please send the records to myself or Dr. Begun first and let us review it with you, because maybe we can take care of it here at Schaefer-Osden Center. When it comes to cosmetics and lids, we have certain surgeons that we like to use, so make sure that we try to stay with the best doctors in the city, and we will help you through that process. the Dry Eye Center of Excellence. As you know, my specialty is dry eye and ocular surface disease. As one of the co-founders of the Ocular Surface Society of Optometry, I believe it's important that we truly get control of this disease process. So again, we talked about refractive versus medical care. You should be doing about 20% of your patients should be having a dry eye evaluation of some kind. Giving exams and free samples is not what it's about. That doesn't help you, it doesn't help the patient, it sure doesn't help optometry. You should be using punctal plugs, you should be using Restasis, you should be using Lacrocerts. And also ABMD. I see that so misdiagnosed in so many places all over the country. Make sure you stain your patients and look for that anterior basal membrane dystrophy. As we know, we can prevent long-term damage if you start treating that early. Contact lenses. I could spend hours talking about contacts, but let me just do some brief things for you. Remember, I was chair of the cornea contact lens section for the American Optometric Association. The things I'm telling you, the same things that we as a group wrote to all doctors all over the country. Number one, toric and spheres. Whatever you learned at school, forget it. Number one, if somebody has a half diopter of astigmatism, show them what astigmatism is like by taking 0.75 and taking in and out of the phoropter. I have never seen a patient with 0.75, I should say never. 95% of patients have 0.75 of astigmatism, or leaning between a half and 75, do so much better in a toric lens than a sphere. We're Schaefer Eye Center, we do the best. Custom torics. If somebody has over 1.75 of astigmatism, first of all, make sure you do a topography. You have no clue whether that's an early keratoconic or not. In fact, in the future, I think we're going to add topography to all contact lens evaluations for a small fee. But custom torics, 1.75 astigmatism. There's not a single contact lens made that is a general brand, Cooper, Bausch & Lomb, Ciba, Alcon, I mean, that really does well above that. You have a plus or minus 5 degrees of astigmatism play in those lenses. With a custom toric, you have 1 degree. So offer your patient the best they can have and offer them custom torics. Now, they may not want to pay for it, and that's their prerogative, but at least learn how to fit it and learn how to offer it. That's your job. Children. All children should be in 6-month evaluations. Do not dismiss a child for a year. That is poor care at Schaefer Eye Center. Anybody 18 years or younger, we see every 6 months. That is our protocol. And never let a child sleep in a contact lens. Always offer our dailies first. If they're not dailies, it's up to you to make sure they're compliant. And never let them sleep in the lens. Remember, 70% of all children are non-compliant, and their complication is up to you to prevent. Prevent it. Don't wait to treat it. And lastly is sclerals. Scleral lens is the finest thing of all lenses ever been developed, and we will have later conversations, but make sure that you learn about sclerals. And if you don't want to fit them, that's not a problem. Refer them to me in Hoover. I love to fit them. Lastly is GPC, invert eyelids. Silicone hydrogen lenses have a problem. They cause splitting, and that's why you stain to see splitting of the conjunctiva, and they cause GPC. We know that. And they also cause infiltrates. We know that too. But GPC is easy to diagnose. Flip the eyelid and you'll see it. And you know what we have to do. Remember, we talk. There's a GPC protocol at Schaefer Eye Center. Remember, on all contact lens evaluations, have your techs do an auto over-refraction over every lens when they come into the office so you know where they are, and make sure you look at the lens on the patient's eye. All extended wear lenses and anybody that is non-compliant, so you know how and what they're doing with their lenses. And that's why we have PRP. And that's what we're going to talk about now. It's Planned Replacement Program. It's up to you, the doctor, to make sure that every single patient explain why this program is better. It costs less money than buying lenses at Walmart. So why would not everybody do it? Well, they don't do it because they don't want to be compliant. It's up to you to help them through the process. You do it with a smile. Now, if they do not want it, that's okay. That's their prerogative. You give them the best possible care. But you have to believe in it to make sure that over 50% of your patients are going in a planned system. Because we know a good practice will get anywhere from 55 to 75% of their patients in a planned replacement system. The next thing is glasses. Make sure all contact lens patients have glasses, especially when they have managed care insurance. You say, by the way, we're going to use your insurance for your glasses, and we're going to go out of pocket for contacts because you only get about $125 with your insurance for your glasses, contacts, but they're going to give you a lot more for your glasses. So make sure all your contact lens patients have glasses. Medical insurance and refractive insurance. We know that's the biggest hassle that you had in school, and you have it now. But it's important that you understand patient's insurance. When I walk in the exam room, I look at which refractive insurance and which medical insurance every patient has. I also look at deductible. And if they have a large deductible and with no copay, I'm very careful about explaining what's going to happen when I do medical testing, because they're going to get billed over $200. And I want them to know that. And they say, look, I can't afford that. You got to figure out what to do, and maybe sell them a wellness exam for less. But know all about the insurance and what is covered and what's not covered. Dispensing from the chair. There's also hours of lectures on this, and I'm not going to get off on too much of this, except you have to understand the options your patient need. We have lots of levels of progressive lens and single vision lens. Please know those options so you can talk to the patient about them. Every patient should have sunglasses. We know that UV causes cataracts, probably macular degeneration, and definitely is better for the patient for seeing. Same with changes in prescription. I see doctors all the time with a pair of glasses change a quarter to a half, and they said you don't need a change. This is Schaefer Eye Center. If they didn't want the greatest care, they wouldn't be here. A quarter diopter at night makes a big difference in the way people drive. If you have a 45-year-old and you undercorrect them by a quarter and they go out at night, then now undercorrected by 1/2 to 3/4 of diopter. Give them what they need. Put the perfect prescription in the glasses every time. You know, we've talked a lot about clinical responsibilities, but let me talk about a few management responsibilities that are important to your staff and important to me. Try to arrive at the office 15 minutes early, because when the patient is ready, you're ready. Your manager and your staff will be so appreciative if you're there to talk to them about what's going to happen that day. Walk-ins, we all get them. That's the way it is. You know, we have 25% no-shows every day, but sometimes you got to deal with walk-ins. And that, if they come in at 5 o'clock, 5:30, that's it. We're Schaefer Eye Center. You see the patient with a smile. And make sure we take care of those patients, because that same patient may be the one that has a retinal detachment, or some of these you really have taken care of. Staff training. It's up to you to make sure your staff is trained up to the most highest level that you can get them to. That's your job, because it makes your job easier. Office meetings, please attend. The staff want to see you there at their weekly office meetings, so you help manage that office. The same with our quarterly meetings. Come join us. We have fun. We learn. We have a great time. Remember, the staff watch everything you do. You are the leader in the office. Make sure you take that leadership role. Schaefer Eye Care Experience starts with you. Again, welcome to Schaefer Eye Center. I know I went over so many things, and the detail is so important. You know, we want to be the best that we could possibly be. We want to give the best care that we can possibly give. We want to be community-oriented doctors, and we want to live up to the expectations of what optometry is. Because you represent every optometrist in this country. You represent every optometrist in Schaefer Eye Center. And we're proud of you for that. That's why you've chosen to be part of Schaefer Eye Center. And together, we can truly give the best care. And that's really what it's all about, isn't it? Making our patients' lives better. Welcome again to Schaefer Eye Center. I look forward to working with you.